here's another vignette. This woman had an uncomplicated vaginal birth after receiving 11 prenatal visits beginning at 6 weeks gestational age. She did not have chronic hypertension, but developed high blood pressure during her childbirth hospitalization. It was recorded in the chart but went untreated, so she had 140s and 150s, was discharged with a borderline blood pressure of 158 over 90, and had a follow-up appointment scheduled in 6 weeks after the childbirth. She then attended a subspecialty visit for a totally non-obstetric related concern 7 days postpartum, and her recorded blood pressure at that visit was 190 over 100. The provider, who was not an obstetrician, recommended dietary changes and a primary care follow-up that was reported in the chart. And a few days later, the boyfriend of this patient or person found her down at home and unresponsive, called EMS. She was declared dead upon arrival. The boyfriend told EMS providers that she had reported chest pain 2 days prior, and her autopsy was consistent with a dilated cardiomyopathy. The review committee coded the primary underlying cause of death as a cardiomyopathy and a secondary underlying cause of death as hypertensive disease based on her autopsy findings. And the committee determined that this was preventable with some chance, so not a good chance, but some chance to have altered the outcome. The committee, the MFM people on the committee felt like, maybe if we had responded differently to this blood pressure in-house, maybe the patient's level of suspicion would have been higher when she started to have symptoms. Maybe if she'd been scheduled for an earlier follow-up, though they argued about that one because that elevated blood pressure was within a 7-day window pretty early. Now we know, since this case was reviewed, ACOG has changed their guidelines for postpartum follow-up for hypertensive patients, saying that really a hypertensive patient should be followed up on between 7 to 10 days after delivery. But many of us may not have scheduled this person for a 1-week follow-up. I'm just going to be honest about that. So they were not sure whether this was like a slam dunk. We definitely could have prevented this. There was definitely an opportunity for prevention, for sure, when she saw this other provider who was not an obstetrician. Could that provider have contacted her obstetrician? Who was her primary care provider, and so telling her to follow up? Could there have been some more immediate follow-up, whether based on her initiative or based on the other provider's initiative? And then could she have come into the hospital when she had that chest pain 2 days before she died? So a lot of things in this case, and you can see how with some of our hypertension-related deaths, it's not just, the protocol. The protocol here would have been like, well, she was in an OB admission and had a blood pressure of 158 over 90. What's her diagnosis? What are we calling her? What are her symptoms? What's the documentation in the chart? Which there really wasn't a lot of. But then, this kind of coordination of care postpartum. And what we can see, so this, again, the number of the rate looks different because the denominator is different. So our preeclampsia denominator here is much, much smaller, so these numbers look different. Again, over the last 2 years, we're seeing maybe a gentle decline in our SMM rate among women with preeclampsia, eclampsia. And interestingly, our racial disparity, again, the black line is black and the green line is white. The blue line is black and the green line is white. We see this kind of interplay that suggests maybe we're closing an equity gap, but we don't really know without many more years of data. Remember, this is just 2 years of data points. The important thing is that we're tracking it, and I do think change is possible because we are seeing improvement. What's interesting about SMM and hypertension nationally is we are seeing our chronic disease rate just escalating as women, age of childbirth is getting older, higher prevalence of obesity, and just increased prevalence of hypertension in women of childbearing age. And this is kind of what's reflected here, is that even though our chronic hypertension rate is rising in the population, our hypertensive disorders and pregnancy rate, this is national data, is rising even faster. So for some reason, there's something about pregnancy-related hypertension that's just going up at an even faster rate than our baseline population. I'm going to skip this slide. It basically just affirms that women with hypertension, with severe hypertension during pregnancy, are much more likely to have a range of different complications, including severe maternal morbidity, pulmonary edema, abruption, length of stay, and a preterm delivery. So we have our AIM hypertension bundle. I want to spend a few minutes here because there have been recent changes in our ACOG recommended management. The bundle, similar to the hemorrhage bundle, focuses on standardized protocols, which I know you already have. And just because of living in these maternal mortality cases for the last year, I want to emphasize that typically The women who are falling through the gaps and through the cracks are not necessarily falling through the gap on the labor floor. It's all of the movement that happens around that. It's in the emergency room. It's when the woman is transferred from L&D to the ICU and the ICU provider doesn't have the same threshold to treat that an OB might. It's when that patient comes back to postpartum. Maybe the postpartum nursing ratio is different and there's a delayed recognition. And then a lot of the issue has to do with, once the blood pressure has been recorded, what's our recognition and our threshold to treat the blood pressure and act? What is our discharge counseling? Are patients who are at high risk for a major event at home going home with an understanding that if they have a headache and they have chest pain, it's probably not GERD, and it may not be stress, and it's probably not breastfeeding. It's that they are really high risk for a true cardiac event. And many 25-year-old women, why would they think that? Why would they go home feeling that? Why wouldn't they just assume it's because they just had a baby and they're exhausted? Unless we kind of enlist them in having a higher level of concern. In terms of response, having a facility-wide management plan, and I'm thrilled that Cheryl is here from the emergency room, because really we have to think about our emergency rooms and our ICUs as an extension of our system. And then again, that culture of debriefs, case review, continuous learning, and partnering with patients. And something we're really emphasizing in the Quality Collaborative is having patient advisors on our quality improvement team, so we're getting some input from patients about where the gaps in the system may be. I wouldn't necessarily know that my patient is having a hard time scheduling a postpartum follow-up appointment without a patient telling me that when they called a certain number, like so-and-so picked up the phone and hung up on them. Like, I'm just not gonna know that kind of thing as a provider. So we really need community representation and patient advisors on our quality improvement teams to tell us when those breaks in the system are happening. So a clinical pearl, in one study, this sounds so basic, controlling of blood pressure is the optimal intervention to prevent deaths due to stroke in women with preeclampsia. But I have to say that even in my short time as a provider, I feel like when women had chronic hypertension and they were at term or delivering and they had a blood pressure of 170 or 180, and this was only 10 years ago, I don't know that we were always treating that, because we had this thing that people would say to me like, well, she's been living like this is where she lives, so this is okay, let's repeat it and let's see if it's above 180, then I'll treat it. That has really changed because of new data. So in one case series that's in the New Practice Bulletin of 28 women who had a stroke in the setting of preeclampsia, almost every single woman had a systolic pressure that was elevated preceding the stroke, not a diastolic. I feel like at some point I was also taught that it was the diastolic pressure that really had more to do with somebody's cardiac and stroke risk. The new thinking is that it's really that systolic pressure being elevated. And of all of those 28 women who had a stroke in the setting of preeclampsia, 54% of them died. So hemorrhagic stroke connected to systolic blood pressure, very high morbidity, permanent morbidity or mortality rate. Any questions about that study? I know it's hard to process numbers when I don't have it up on the slide, but basically we want to have an increased sensitivity to the systolic blood pressure. This is from the new committee opinion from January. We want to treat with IV labetalol, hydralazine, or oral nifedipine. These are the recommended first-line agents, regardless of what she's already on. So if she's a chronic hypertensive with having an exacerbation and she's on methyl-dopa or something else, we want to treat with a fast-acting agent if she's anywhere above 160 over 110. And I just had this happen to me on the labor floor on Sunday. Patient came in, we placed an IV, her blood pressure was 210 over 120. The IV fell out. The nurse is like, I can't put in the labetalol, let me get a new IV. And then I walk into triage and she's fussing with the IV. And now it's been 25 minutes since we recorded the 210 blood pressure. Now she's not doing anything wrong, she's focused. I have to get the labetalol in, I need the IV, and I'm like, stop. Let's get some nifedipine, let's give it to her PO, and then we will come back to this IV and get her MAG going. But you realize that in those moments, especially if we're not there, and if that person is alone, that nurse is alone, just at the bedside trying to put in all these orders, it's going to be hard to prioritize without that physician voice saying, I want to get the blood pressure down first, then we will hang the MAG, then we will do her health labs, then we will do all of these other things. And that kind of prioritizing of the response has really, I think, been sharpened by many states having maternal mortality and morbidity data, and by having more research on the safety of oral nifedipine and the safety of nifedipine specifically in the setting of magnesium. that risk that we used to be really worried about is really just a theoretical risk, and we have lots of data now that shows that it's not really a concern, especially not a concern against the possibility of a hemorrhagic stroke.
What risk is that? I'm sorry.
So I feel there was this kind of theoretical risk that having someone on a calcium channel blocker while also having them on magnesium would lead to this like massive dopaminergic response or neuromuscular response, and really that's never actually been noted in the literature. So we feel ACOG now recommends starting oral nifedipine, short-acting nifedipine for an elevated blood pressure, and also obviously recommends magnesium prophylaxis in anyone with a systolic over 160, and we think that that's perfectly safe at the same time. The other major change in that ACOG committee opinion that came out in January is that magnesium is not considered an antihypertensive in this setting. So starting the MAG first, and I have heard these words come out of my own mouth for years, I only really changed my practice last year. I feel like I've told so many residents, start the magnesium first and the blood pressure will come down, then we'll treat her. I don't want to tank the patient and then the baby will crash, right? Like it's very kind of, I don't know, familiar stream of words. That is very much not the teaching now. We're seeing that that's really contributing to delays in treatment, that women are getting started on MAG, which is just seizure prophylaxis, and then they are, having strokes due to untreated blood pressures, particularly the women who come in with a history of chronic hypertension and have superimposed disease. Any other questions? So one of our kind of measures that we're focusing on in the Quality Collaborative is this timely treatment of severe hypertension measure. We are asking all 31 hospitals to report to us. And right now you're just reporting to us. The hospitals aren't seeing each other's data. They're just reporting it to our collaborative team. The percentage of women who have a blood pressure diagnosis, who are getting a medication within 1 hour of a severely elevated blood pressure. And that measure, we didn't make this stuff up. The AIM program nationally is asking us to collect this information from our participating hospitals. There's even talk of legislation that makes these bundles mandatory that's currently being considered by Senator Cassidy, which I just found out yesterday. I don't know how I feel about that, but if, it's just, I think people are so disturbed by this kind of trend in maternal mortality that they're trying to think about what it is that we can do to support action. So where are we at East Jeff on this measure? First, I want to congratulate you for collecting the data on this measure. This is not an easy measure to collect data on for a team because you have to figure out, okay, who are my patients who have a severe hypertension diagnosis, severe gestational hypertension or preeclampsia superimposed, even if they have chronic hypertension. Then you have to figure out, well, how many of those patients got treated within an hour? So you have to look at your EPIC reports, when was the blood pressure documented, when was the medication administered. And we're a little bit up and down. That's okay, but we should try to figure out how to go up on our treatment. And I think that, there's going to be this variation that happens a little bit over time. And this is January 2019, this is August 2018. So just a little bit of variation still maybe as people are becoming more familiar with the new protocol. From other hospitals, I'm learning that some of the dips happen to be like, well, she was coming up from the emergency room and her blood pressure was recorded down there and it took an hour to get her up and get her hooked up here and we didn't know that her pressure was that high. Do I count that? Yes, you count that because it happened, right? The patient doesn't care where she was in the hospital when her blood pressure was high. She still needed the same treatment. So we have to adapt our systems to those kind of complicated scenarios. I'm going to stop soon. But some general protocols that AIM, does everyone know what I mean by AIM? So it's the Alliance for Innovation on Maternal Health. It's a quality program supported from California, now going national with 30 participating states. So AIM, and we are participating in AIM, recommends that every hypertension protocol on the labor floor includes these requirements. So notification of the primary provider, that's us, if the systolic blood pressure is more than 160 or the diastolic is more than 110 for 2 measurements 15 minutes apart. After the second elevated reading, the treatment is supposed to be initiated as soon as possible. And that measure that I showed you is assessing whether the treatment was administered within an hour. Now, that doesn't mean we need to wait that long. We would ideally be treating someone much, much sooner than an hour. But the measure gives us a little bit of room because we don't want to be overly punitive if people are confirming a blood pressure or if there's some kind of extenuating circumstance. Like I said, the treatment of the blood pressure does not include max sulfate. We want to see in the protocol that there is some kind of escalation for a person, a patient who is unresponsive to standard treatment. So you give, nifedipine 10. You give nifedipine 20 minutes later. You give another dose of nifedipine 20 PO 20 minutes later. Now you've switched based on the ACOG protocol to labetalol 40 IV, and there's still no response. Now I want to see in your protocol who are you contacting? Who is the on-call person who's available to you? It could be a maternal fetal medicine specialist, depending on your hospital. It could be a critical care specialist or a hospitalist, an internist hospitalist. But whoever that is, that person should know when you're developing the protocol that they're going to be getting calls for this because they should get brushed up on their obstetric management and think, okay, what am I going to tell this provider when they call me? Am I going to recommend a labetalol drip in step down? Am I going to tell them to go to the ICU to get their drip? That really depends on your hospital and your resources. Is this an indication for a transfer? Typically we don't want to transfer someone who has an uncontrolled blood pressure and put them in an ambulance. So we need to think about what is that protocol going to be at this particular facility. And then the outpatient follow-up really should be happening, as I said, between 7 and 14 days postpartum. We want to describe our patient support plan. Ma'am, you have an elevated blood pressure of 160. If this happens again, we're going to want to treat this in an hour. Please let us know if you have a headache. Do you feel like you're getting your medication on time? How do we partner with those patients and really say, okay, you're leaving the hospital now. This is why we need you to come back in a week. This is different than what you might have expected. If you can't come back in a week, maybe this is someone who's going somewhere to get their blood pressure checked and we're coming up with sort of a tailored plan. And we really want to see an interdisciplinary review of any cases of a woman with severe hypertension who ends up going to the ICU. That's the definition of severe maternal morbidity in this context. We want to be developing that systems learning and that culture of change. How are you doing? Any questions about hypertension stuff? Are you sure? I feel like you have a question. Really?
That's a nice question. Not about that.
Do you want to share any of them? Okay. This is the benefit of having a small group because I'm like, you look like you have a question, you don't look like you have a question, you look like you have a question, you don't look like you have a question. So I'll move on. So
My question was,
okay.
What are we going to do here? Are we going to have a maternal fetal medicine doctor come out on Sunday night at 3 o'clock in the morning? Are we going to have a hospitalist come? Are we going to have we don't have any intensivists here. So who does that here at East Jefferson? Because I don't think we're going to get Dr. Chow or Dr. Miller to come out here and manage these patients.
So our order, Dr. Hogan, the power plan for the labetalol, hydralazine, and nifedipine it's the verbiage exactly from the ACOG bulletin, and it says if the patient is not coming down, the pressures are not coming down, we are to notify MFM. So we would.
Do they know that?
Well, they were part of the
approval.
Yeah,
She said I had a question. And
they were part of the
So I think this is also an opportunity because I work with the same MFMs that you work with. I'm very, very familiar with both Dr. Chow and Dr. Miller, and I think we have a couple of MFM groups managing the entire city, and that is both a challenge, but it's also an opportunity because we are saying that the entire city should be managing hypertension exactly the same way, right? Every single birth hospital in the city is in this collaborative. There's no one in the city who's not in this collaborative. So I feel like our MFMs, maybe what we need to do is maybe a plan to study act cycle is that we get with our MFMs and say, there's 6 of you or 14 of you, and there are 13,000 births. What is our plan for escalation of care? Because I can tell you that the maternal deaths that are happening in New Orleans, we all know it's a small community. We know where they're happening. We know when a critical care specialist is needed, when the ICU is needed, and when maternal fetal medicine input is needed. So it is an opportunity, Dr. Hogan, to kind of get a true kind of feedback from our MFMs, like, okay, just a reminder, we're going to call you in this situation. What is our plan? Are we going with labetalol drips? What do you feel comfortable managing at East Jeff? We have this kind of mesh of people driving around back and forth between all of these facilities. So how do we make sure those patients get seen in a consistent manner? I think it's a great point. The point I want to make here, we've talked a little bit about the disparity. So this is our severe maternal morbidity rate and our black-white disparity. I just wanted to congratulate East Jeff for being one of the first hospitals in the state that is taking on the challenge of actually looking at your timely treatment measure and your other measures and stratifying them by different things to understand if there's a disparity. Now, many things impact racial disparities. The person's health, the person's access, but also hospital quality of care. And I think the best way for a hospital to show that it's not their quality of care that's feeding a racial disparity is by actually stratifying on their process measures. So if you can show all of our patients are getting treated within an hour, this is not something that we are necessarily doing differently to our patients here. Our patients may be coming in with a different level of risk. But I feel like we can't really say that unless we show our process data. So congratulations to Paula and Lisa for really taking the step of saying, well, if we look at our timely treatment measure, and let's see what it is just in our Black patients, is that looking different than our overall timely treatment measure? And I don't know, Lisa, what all of these lines represent. It looks like you have a line for, this is your overall timely treatment rate in red. This is a few months of trying to stratify your measure Black versus white, or Black versus everybody else patients. You have it stratified to see whether there was an appropriate physician order, but then the medication still didn't get given on time, so that helps us understand, well, maybe our docs are giving the order on time, but there's a delay happening after the order gets put in. So she's stratified by that on this green line. I just wanted to congratulate you for digging deep into your data, because without digging deep into our data, we